As we discussed in the last hour, multiple sclerosis patients are asking the government to approve a new surgery for MS. The surgery is already used for other medical conditions, but not approved for multiple sclerosis. It involves unblocking a vein in the neck to allow blood to move more freely. But we just learned yesterday that this unapproved procedure was actually performed twice on MS patients at Victoria General Hospital in April. To find out how that happened, we've reached Dr. Brian Weinerman with the Vancouver Island Health Authority. He's the Executive Medical Director for Diagnostics. Dr. Weinerman, good morning to you.
Good morning.
And how did you find out about these unapproved surgeries?
Well, it was actually reported to me by our chief medical officer, I believe, and I think it was because of one of the people that had it done reported it to local news media. I believe that's the way it happened.
And any idea how it happened? I mean, is this the kind of thing that wouldn't be very surprising? I suppose if a doctor just books surgery time and it's an approved procedure for something else, or how did it happen?
Yeah, well, I think we've obviously started reviewing the entire incident and just to find out just how it did happen. And indeed, the particular physician was actually asked to do the procedure by another physician in Vancouver. And the physician did make it clear that, well, sure, he would try as long as there were other symptoms in the individual for which they usually do the procedure, that is swelling or those types of things. And as you've mentioned earlier, the venoplasty that is done is not that is done for certain indications. And the fact that the patients had MS, you wouldn't necessarily want to stop them from having this procedure done if they're having symptoms from another type of illness. Having said that, he does feel that he was somewhat naive in thinking that was really the reason for the procedures, and as you know, we've only done 2, and we're going to stop doing them unless they're under the umbrella of a clinical trial and an investigational trial. Okay, and I want to ask you about that in a moment, but just before we do, let's hear very briefly from a guest we had on the program an hour ago. We spoke with MS sufferer Joyce Perrin.
The treatment is something that's been around for a very long time. From all intents and purposes, people are benefiting from it. I don't see any problem with having the testing and treatment going on at the same time as the clinical trial.
So that's Joyce Perrin on the program earlier, and surgeons already do this procedure for patients with conditions other than MS. Dr. Weinerman, why not allow the procedure for people with MS, with no other conditions?
Well, I mean, that's a good question. I mean, on the one hand, you have the clear emotional response from people who are desperate for any type of treatment, and the question is, why not? It gives them hope, and as you say, the procedures has been done for a reasonable period of time. But the medical literature is replete with situations where we did things which we thought would help and certainly not do any harm, but lo and behold, when the actual trials were done, we found the opposite was true. I'm a medical oncologist by trade, and certainly in the literature in medical oncology, we've used vitamins to try to stop things, and things that stimulate red blood cell counts to help patients. And when we've done them in trials, we found that in fact, not only did they not help, but they did harm. And so we don't know, despite the early wonderful-looking results, that we might, for some segment of patients, actually make things worse. And one of the things we don't want to do is do harm, right? We don't want to do harm to people. And unless you do this in a clinical trial where you're looking at everything that's going on, you may not pick that up, because MS patients, bad things do happen, and so if something should go wrong, we would probably not detect it if we were just doing it. Okay, albeit that the clinical trial may or may not pick it up, and furthermore, the clinical trials may have trouble getting done if everybody can just get done the procedure, because why would you why would you go into a clinical trial if you could just get it done?
Okay, well, that point notwithstanding, I understand. I certainly hope you're still there, and I understand your earlier point that perhaps there could be unforeseen consequences. For instance, for MS patients, that other people having angioplasties may not have suffered or come upon, and that's why you need to do the trials. But what about this idea of off-label uses? I mean, we heard from Dr. Mark Godley at the Falls Creek Center in our past hour in Vancouver, saying that off-label uses occur in medicine all the time, and that raises questions about what other surgeries or procedures might be done off-label in island hospitals. How do you monitor that?
Well, I mean, I think that's correct. I mean, what we want to, but it's not right. I mean, what we want to try to do as best we can is as we move things forward, is try to have everything as evidence-based as we can. We want to have strong evidence for what we do, that it does good and does no harm. For many, many, many years, we have done a lot of off-label things, and we have often gotten into trouble with them. You're always going to be before a patient, and there are sometimes there's just not going to be enough evidence to know which way to go, and therefore you have to go by whatever you've learned and the best evidence you have, and that's always going to occur. We're never going to have evidence right up the yin-yang for every particular medical condition when a patient confronts you, and you'll have to go to the evidence and say, well, my bet is this is the best treatment. But where we can, and where we're doing significant conditions, and even perhaps some insignificant ones, we should try our best, especially nowadays, to evaluate these things as critically as possible, because not only are we using this procedure, we may therefore be knocking people out of the lineup, if you want, or putting them back in the lineup, where the procedures can do a lot of good. So we have to be careful about the procedures, and the fact that we've done the wrong thing in the past doesn't mean we should continue to do the wrong thing.
Will the doctor in this case be disciplined at all?
We've done the review, and I've sent our review in to our chief medical officer, and he will look at it and make some decisions.
Can you tell us whether you've recommended discipline?
That will be looked at on the review. I really can't talk about the actual process.
Okay, but back to the issue itself briefly before we go. Do you foresee this procedure for MS patients becoming approved for island hospitals? I know you can't say with any certainty, but
I mean, I think if the procedure shows that it is of benefit, then it probably would be. My bet would be, and I don't have a better crystal ball than anybody else does, but my bet would be that there may be some people that are helped by it with particular anatomies, but that it's unlikely to be okay for all groups of people. But I really don't know, and so if it shows to be of benefit in the clinical trials, of course, we'll be adopting it.
And if it does, given what you know about the schedules of the clinical trials and clinical trials in general, would you be willing to bet again on how long that might take?
Well, it's going to take some time, but again, it will depend a little bit on how spectacular the success is, right? I mean, if this is the answer to MS and everybody's turned around and everybody gets better, then actually the clinical trials aren't going to take that long, because when you get great big types of success, you quickly find out that it works and things actually move along fairly swiftly. If you get little groups of people that might do a little bit better, or you just improve things just a little bit, the clinical trials are going to have to take in many more patients, and you're going to have to go much longer. So if it really is a home run, I think we're going to see things can turn around fairly quickly, and hopefully we'll get this out in about a year or so. On the other hand, if it's just inches better and they have to really interpret it and look at all the subgroups and mull over the data, it's going to take longer, but then the impact of that procedure is obviously going to be less.
Dr. Weinerman, thanks for this. Thanks for joining me this morning.
Okay. Bye-bye.